Good evening. Welcome to this group discussion on UGI bleed. UGI bleed is a very common clinical occurrence, and I think we should have very clear ideas about what needs to be done and how you handle a case when a case lands in your either OPD or your emergency or whatever. All right. So we will look at some very, as usual, very practical aspects of how we should approach this problem. And let's see how much you guys have read. So, Samir, what is UGI bleed? Is there?
Yes, sir.
Yeah.
Yes, sir.
Yeah.
Sir, it is a plate which is localized to esophagus, stomach, proximal to the ligament of Brights.
Correct. Anything proximal to the ligament of Treitz is an upper GI bleed. Okay, that's correct. Yeah. DJ
Sir,
Flexion.
sorry to interrupt, sir.
Yeah.
Sir has joined. Sadashivya sir has joined, sir.
Oh, very nice. Hi, welcome.
Thank you. Thank
Dr.
you.
Sopi Mutt is one of the leading surgeons and endoscopists from Hubli. Okay, and it's
Yes,
a pleasure, sir. It's a pleasure, sir, having. So please chip in and give your bit whenever you think it's required. It's not an interruption. So please feel free to add or subtract things from this class. I think our guys are very fortunate that you have joined this group, this talk today. Very nice. Thank you. Yeah.
Thank you. My pleasure too.
Yeah.
Thank you.
So bleeding from the GI tract proximal to the DJ flexure is the UGI bleed. So we usually have a group discussion. So we pose a question and give an answer. The students get to answer it. And if you want to add to the question, as I said, please feel free. So, Ainas, how does UGI bleed present?
So it can present in the form of melena or hematomesis, sir.
Okay.
And sometimes so there are two forms, sir. Like one is overt, which will present like this, and the other one will be occult, which will be non-specific, sir, which is not visible, sir.
All right. So you're sort of there, but not completely there. There's a spectrum in the bleed. So I'm giving you a hint. There is a spectrum. And so depending on which end of the spectrum the bleeding is, the patient's presentation differs. So can you understand when I say it's a spectrum? What would be the least form of a GI bleed?
Sir, maybe like a tinge or blood clots in that form,
Do
sir.
you need to see blood clot? Do you need to see
No.
Yeah. Can you have GI bleed without ever seeing what it is?
No,
outside?
sir. No, sir.
You can't?
Uh,
You can?
sir, yes.
Anybody
Sir,
else?
Akkal
know?
bleed. Akkal bleed, sir.
Yeah. Okay. Knuckle bleed. You don't never see it. That's a very classic thing. And what is the other end of the spectrum?
Akkal bleed and obscure bleed, sir.
Correct. And what is the other end of the spectrum?
overt bleeding.
Yeah, overt, such a severe bleeding that the patient presents with shock. All right. So
Yes, sir.
now you know now that you know that there's a spectrum of bleeding, what would be the presentation? How would it differ?
Sir, in obscure bleeding, the patient will come with the complaint of bleeding, sir.
Right.
And in akkal bleeding, the patient might have anemia, and during the evaluation, you will find with endoscopy or colonoscopy.
Okay.
Overt
Oh,
patient,
is that how you think that somebody's GI bleed is detected? Kurushanta Prasad, welcome. I'm very glad that you're here, sir. Topi is here as well. And so I think it's a lovely experience for all of us to have all of you on board. Great. Yeah. Go on, Vinod. Yeah. Is that how, do you do endoscopy and colonoscopy to know if there is occult bleed?
Sir,
Stool for
is a patient
blood.
Yeah, you start with the simple things, right?
stool for akkal blood, yes.
Yeah, stool for occult blood. So depending on the spectrum of the degree of bleed, these are the things that the patient may have. You may not even, he may come with fatigue and a giddiness, and if he's got a marginal ischemic heart disease, because of anemia, he'll get angina, and they discover that he has anemia. And you go looking for anemia, and you'll get fecal occult blood, and that will tell you that will direct you towards the investigation of the GI tract. The classical ones, of course, are the hematemesis and melena. Hematoschisia. What is the difference between melena and hematoschisia, Samir? Yeah, go on.
The color of the
You're there, yeah, go on.
stools
Be
will be
specific.
malina, sir.
Yeah.
Black
What's-
and hemoptysia will be bright red.
Yes, it's
light.
like blood. Yeah, it's like blood.
Yes.
It's slightly altered blood, but melena will be black and it will have a specific unforgettable smell about it. Okay, it is digested blood. That's the difference between melena and hematochezia. And you can have patient presenting with collapse and shock. He may neither have hematemesis nor melena, nor GI bleed, nor hematochezia. The patient has shock. And then you start looking at the reasons for shock and you end up understanding that there is a GI bleed. All right. So how would you know that when there is no hematemesis or melena, but still patient comes with shock, there is no trauma? How would you know that there could be something going on in the GI tract? Go on. Nitya, you want to take it?
The patient will have this thing, thready pulse, like proper.
Patient is in shock. I've already told you, collapsed and shock. You don't know what, there's no trauma. You don't think there is an intraperitoneal bleed. So the only other thing, you think it's a hypovolemic shock. Patient is pale. Okay, it could of course be cardiogenic and other kinds of shock. I'm not getting into it. You know that it is probably an anemia. The patient is pale and in shock. How do you know that there is a possible GI bleed? Clinically, when you see them in the casualty, what are the two things that you have to do?
Mm,
If you insert an RT or if you do a
Correct.
PR.
Exactly. Put an RT, see if there is any altered or fresh blood and do a PR and look at your fingertip and then see if there is an issue. That is the kind of approach, practical approach that you need to have. Okay. So this is the spectrum of presentation of patients with an upper GI bleed. So
Sir,
this
one
is,
small doubt, sir.
go on.
Sir, hematochezia can appear in upper GI bleed, sir? Like
Absolutely. Absolutely. All right. Many times when you have a patient with hematochezia and in shock, you don't straight away go for a lower GI endoscopy. You first make sure that there is no upper GI bleed. So the presence of fairly fresh or slightly altered blood in the rectum depends on the rate at which the bleeding occurs. All right. So it could be in the upper GI tract.
yes, sir.
It could, of course, by definition, it may be just beyond the ligament of Treitz, so it doesn't become upper GI by definition, but it need not necessarily be colonic. It could well be in the small intestine. It could be in the jejunum, for example, an AV malformation or a duofoil lesion or something like that, or even a tumor. So you have to have a very open mind about the source of bleeding when you have hematochezia. And the first thing I always do, and it's recommended as well, is that you do an upper GI. Make sure that there's nothing there. And if you know that there is no upper GI bleed, then do the colonoscopy. And if that also doesn't show an obvious lesion further on in your investigation, then go for the investigation of the small bowel. Okay, that would be the sequence of events. So this is a straight from the textbook kind of question. Upper GI bleed causes, Nikita. And I would like that in the order of frequency. That's how you must remember, and that's how you must understand the issue. Why do you think the order of frequency is important? Nikita, let's start from there.
Because of more frequent things we need to rule out first, sir.
First, exactly. Correct. So rare diagnosis is rarely correct. And so you must look for the common ones and you must know what the common ones are. Go ahead. Give me a list. And as I keep saying, try and classify it, for you to understand and remember what would be the kind of lesions that you're looking for.
So first would be anatomical classification,
Okay.
esophageal, gastric, and duodenal.
Okay, good.
Esophageal would be varices, esophagitis, and in case of malignancy.
Okay.
Gastric would be peptic ulcers most commonly. Then the malignancy or tears, Mallory wish tear.
Okay.
Duodenal will be again ulcers first and AV malformations.
Okay. All right. But is that more important than, is anatomical more useful than, or is pathological more useful?
Pathological
Clinically.
is more useful.
Okay. So if you look at pathological classification, What would be the commonest cause?
Varices would be the most commonest cause, sir.
Okay, go on. Tell me. Yeah. Go on. We will.
Then the ulcers.
Okay. Peptic ulcers,
And
you mean? Okay.
yes, sir, peptic ulcers.
Okay.
And malignancies would
Yeah.
be the
So
next,
you
sir.
must, yeah, that's why I said you must think just instead of just listing anatomical causes, it would be useful to understand the pathological causes and their frequency. Vinod, do you want to alter it or agree with it or disagree with it?
Sir, varicose bleeding will be 20% of the upper GI bleeds, sir, and followed by peptic ulcers and followed by
So if you have 20% as the highest, and say peptic ulcer is 15% and the others are all 4%, how will it make up 100%? You'll probably stop short at 50 or 60%.
yes, sir.
Okay, this is the average world frequency. 50 to 60% is peptic ulcer disease, all right, or related, esophagitis, duodenitis, gastritis. Varices is 5 to 15%. The others are all 2-3%. Okay, vascular. Nobody mentioned vascular, but that's one of the things you must understand. I, in fact, mentioned it like Dulafoi. Dulafoi can occur everywhere. Okay, neoplasms, you may think it's very common, but it's only 2 to 5% presenting with upper GI bleed. And very rare things like, hemobilia and hemosuccus pancreaticus and things like that can occur in about 10%. They come under the miscellaneous category. Do you think there is any difference between a world average and an Indian average?
Peptic ulcers, sir.
Sorry?
Peptic ulcers might be common in India.
It's there in the other ones also. I'm just going back on this. Even there, it's 50 to 60%, 55 to 674, it says. You can take it as 60%. Anything in India? Any of you looked at Indian series of bleeding, upper GI bleed? During your work, preparation for this talk, for this discussion? Any of you? Did you make an attempt to look at the Indian series? You should have, okay? And there are enough Indian series as well, fairly recent ones. This is from Shimla. And what is interesting is that, of course, the percentage of peptic ulcer disease, which was like a world average, in 2005, 10 years on or 15 years on, it has become less. It's only 45%. And look at the increase in the portal hypertension related, that is varices related disease. We don't know why, probably more alcoholism, probably more chronic liver disease from infective hepatitis and the like. But there is literally a almost threefold or 2.5 times increase in the variceal bleed. So Indian scenario does change a little bit as far as the incidence is concerned. Okay, Mallory-White and reflux, these are all the other ones. But as I keep telling you guys, when we have these kinds of discussions, it's always good to look at some Indian studies and learn to get Indian data. And if you don't find any, what would you do, Vinod? If you don't find any Indian data, what would you do? Are you there? You must plan it. If you don't have Indian data, what would you do? As I said,
Study.
Do a study. That is an indication for you to look at. Very simple. How long? What does it take to get an incidence of upper GI bleed in the Indian population? Okay, so that must give you a hint to what study you should undertake subsequently. Okay, that is the importance of the cause. This is a very simple, no trick question. Is UGI bleed a medical or a surgical disease? Sanya?
So majority of them belong to surgical aspect only. Sir.
All right. Why do you say that? Let me see how we are. What made you say that? Whether you really analyzed that statement or not.
Yes, sir, because most of these causes can be dealt endoscopically.
Then how does it become a surgical disease? What percentage of endoscopies are done by surgeons? I and Sophie have been saying for many years that, surgeons must be regular endoscopists, but that's a different issue. But generally, what percentage of surgeons do endoscopies in this country? Any idea?
No, sir.
No. Okay. It's actually, I'm not considering endoscopy as a surgical issue at the moment because most surgeons, there are some exceptions like me and some others, like Sophie and Rushant Prasad, but we are exceptions. Most people don't do endoscopies. So that's still under the umbrella of medical gastroenterologists. So how often do you do surgery for GI bleed nowadays? Let me rephrase this question.
Not very often,
Not
sir.
very. So it is actually a medical disease. And look at this. I'm trying to graphically say from the 60s to the 2000s and beyond, how the role of the surgeon is drastically diminishing because you don't need surgery for endoscopy. And I'm giving you some very interesting data as we go along, which says that surgeon is, not all that unimportant. And if you look at the literature, for example, you can see that earlier, if you had a total of 352 pages on GI bleeding, the amount of surgery written about was only 8%. And in another big book, as it were, GI bleed occupied 75 pages and there's nothing on surgical aspects because all of it was dealt with only with medical or endoscopic causes. Okay. So the point is that literature and the common practice tells you that it has actually become a medical disease. And so what should the surgeon do? And this is what some of us have done. I wish more and more of you do it. I'm a little concerned that you guys aren't doing endoscopies in Sagar, but what you should do, you can't beat them, you join them. You become an endoscopist, and then I think you should deal with it. And it has very practical implications without casting aspersions on any of our medical colleagues. I'll tell you certain real issues that come up in patient care, which can adversely affect outcomes. And it's a very practical thing, and I'm going to ask my colleagues to chip in as well. And you'll find that it is important for surgeons to do endoscopy. So I then ask myself, is it really that bad for surgeons that there is nothing written about it, nothing done about it? This is the interesting thing that you need to understand. It really is not that bad. And I have quoted one paper, 2021 paper. There are many more, which tells you that the mortality from the bleed has not changed in the last 45 years. Surgery is not done. Endoscopically, everything, we all think that the bleeding has stopped, but the mortality has not changed. And the number of operations for complications has not reduced. So if you look at busy centers, the number of operations that are done for complications of DU, both bleeding and stenosis, has really not reduced all that much. Number of operations for non-complicated ulcer has completely disappeared. That's a different issue. But for complications, people still have had to do surgery. And in severe cases, the rebleed rates after all kinds of interventions, non-surgical interventions, the rebleed rates are so high that the best figures, the best data for minimal rebleed rates are still in surgery. The things against surgery, of course, are the complication rate. I told you mortality is the same. So if you look at outcome of any intervention, you look at rebleed rates, morbidity, and mortality. All right. So rebleed rates are the best as far as surgery is concerned. Mortality the same as any non-surgical intervention, but morbidity like chest infection, DVTs, intra-abdominal sepsis, wound sepsis, and things like that are higher in surgery. And that is why people go for non-surgical methods. But please note, the best rebleed, I'm repeating the third time, the best rebleed rates or the minimal rebleed rates are achieved only in surgery. Can I invite comments from Sophie, please? Dr. Sophie Mutt?
Yeah, I perfectly agree with you that, but we do need to, in as and when there is a recurrent bleed and all that, especially when the endotherapy has failed, say twice is acceptable thing. And when the patient is hemodynamically not very stable and goes into repeated hypotension with a spurt of bleed, arterial bleed, I think surgery may be again a good option rather than this one. So I think the surgery has a role, but because the patients don't reach the surgeon in time or primarily to the surgeon, we have stopped seeing them. But still, we do keep seeing these patients once in a while, and we have operated maybe once in a year or once in 2 years, but we do go in sometimes in the arterial bleeds of especially duodenal ulcers and all that.
Gurushantappa sir?
Yeah, yes, sir. Rightly mentioned. For the postgraduates, like sir mentioned in between, it is exactly mentioned in the textbooks. Even though incidence of peptic ulcer disease has come down drastically, but the complication rate related to peptic ulcer disease has not come down.
Yeah.
In the form of the three commonest, it will be asked for the postgraduates, the three commonest complications associated with peptic ulcer, which have not come down by any means, is one is bleeding, second is perforation, third is obstruction. Any combination of this, again, it will be asked in the examination. They are called concurrent complications, which is also high. Concurrent complications, any combination of out of three, two combinations. Sometimes it will be all three. So this has not come down. So please remember these words. The sir has rightly mentioned in the middle, like at any cost, this has not come down, even though incidence is less. Yes, sir.
Thank you. So I asked this question, I'll give you the answer here. It's less than 25% is the endoscopy done by surgeons in the world today. And and that thing, this yellow thing must come right up there. I hope you're seeing my pointer. We must reach 50%. That should be, it should be equally divided between the surgeons and the physicians. Now, let's look at the practical aspects of this. We know when you have a patient with an upper GI bleed, what are the major issues that you would like to address? I'm talking generalities.
Sir, to maintain the volume and aspiration, sir.
One is
Patient may go into shock.
hemodynamic stability. Okay, agreed.
Yes, sir. One more is aspiration.
Okay.
And the emergency,
Don't always think of only patient in shock and a major tremendous bleed. What are your concerns as a surgeon who is faced with a patient with GI bleed, upper GI bleed? One is resuscitation, you said, hemodynamic stability, and monitoring. You have to monitor them. Okay. What else? You need to have good venous access to give them fluids and blood if required and things like that. Okay. Good. Yeah. Okay. What else do you think? What else should you worry about then?
Airway, breathing.
All right.
And if the patient's
this is what I call analytical thinking. Okay. Stepwise analytical thinking is what you guys must develop. Not just reading a textbook and blurting it out in an exam. It's a practical issue. So without knowing where the bleeding is from, what will you do next? So after stabilizing the patient, what would you do? What is your priority?
Look for the
getting a diagnosis. How we do it, we'll get into it. Getting a diagnosis. Yes. Okay. Once you stabilize the patient, you have a diagnosis. What else will you think of? Treatment. In treatment, what are your options? That's the next thing that you think of. You understand? Yes, all the things must be analyzed before you do it. So resuscitation and monitoring, you need to get a diagnosis. Choosing the intervention. We'll talk about what are the interventions available to us as surgeons or as treating doctors. Then you have to recognize, as Sopimat very clearly said, some people need surgery. Who are these people? There must be some solid data to support that decision, right? So recognition of the need for surgery. And then once you decide to operate, what are the options that are available? So the whole discussion will be on these things, not of course very much on resuscitation and monitoring. We have talked enough and more about it. So I'll skip this. Okay, but these are the points that you must understand in a GI bleed. The extent of bleed is always underestimated. So you have a good access, strict monitoring of vitals, basic blood workup has to be done. Keep 2-3, don't worry about blood being wasted. Keep 2 to 3 bottles, if not 3 or 5. I may have overdone it because blood is a precious commodity. Because you can't go chasing for blood in the middle of the night, they can bleed anytime. So keep 2 to 3 bottles of blood at least in the fridge, cross-matched and ready. All right, that is the overriding importance you must understand is this first statement that generally all of us clinicians underestimate the bleeding. If it happens with a wound, it's obvious outside. When it is inside the GI tract, we underestimate it. So what would be the workup that you would classically do? Go on, Samir.
This blood count, sir.
Okay,
PTINR.
just list them. Yeah,
And
PTINR.
then
Okay, obviously these are the
liver
main
function
things.
test,
Yeah,
sir.
yeah. You need to understand whether if there is an abnormal PTINR, is it secondary to some liver disease? You must have a platelet count and obviously CBC. Now, somebody has a GI bleed, he's not in collapse, but he may be continuing to bleed. How would you know whether he's continuing to bleed or not? There is no obvious melena or blood that comes out. Also remember that if the bled in the upper GI tract, the blood may come out 2 days later. Okay. And not all, if you have a duodenal ulcer, not all of it has to bleed back. So your Riles tube may not show much blood, but the patient may still be bleeding. How would you know that? How would you monitor? That comes under monitoring. How would you know that? Praveen here? I don't know if I saw him.
Sir, yes, sir.
Praveen, yeah. Tell me, Praveen. Yeah.
Sir, hematocrit monitoring, sir.
Good. I'm glad you said hematocrit and not HB. How is hematocrit done and what is the cheating that occurs usually? Any idea?
During HB, there might be dilution, sir, but
Yeah.
hematocrit shows
They will do hematocrit 3 times of HB.
Yeah, that is the cheating that happens. So you must tell your lab, I don't want 3 times of my HB as my PCV. Okay, I want it to be the blood to be spun. It has to be centrifuged and a proper PCV to be given. That you must make sure with your lab. Okay, so checking the PCV 2 or 3 times a day is what is recommended. And if it keeps falling, then then you know that there is continuing bleeding. Okay, anything to add, sir, at this point, Sopimat?
I think it's perfectly okay what has been mentioned. And of course, you mentioned about the hematocrit value, and that's a very useful thing to monitor. I think it's absolutely fine.
Yeah. Gurushantapa, sir?
Yeah, nothing, sir. Riles tube, I think you mentioned, sir, Riles tube output.
Yeah.
Maybe volume of melena also.
Yeah.
How many times? Because they will have a hurried bowel movements.
Right.
So that also should be measured.
So,
And
sorry.
I just missed one. What is often missed is the mean arterial pressure, which they should look into.
Very true.
Because that reflects the vasoconstriction effect, and suddenly they go into decompensation if this mean arterial pressure is already compromised. I think that indicates, and also we should be focusing on that, which patient need to be prioritized on resuscitation and how you need to.
Very true. Very true. Now, again, when I say treatment options, I'm talking about broad headings. Okay. So all the armamentarium that you have in a very well equipped hospital, that's what we look at. So Nikita, tell me, what are the options that you have? I need only the broad headings. I don't need individual interventions, broad headings.
Sir, endoscopic intervention.
I'll give you, I'll start with a medical intervention. We'll start with medicines,
Yes,
right? So
Yes,
medical
sir.
interventions, you mentioned endoscopy, right? You mentioned radiology. Then
Correct. Surgical intervention.
correct. Those are the things that you have to worry about. Not worry about, think of. Right? These are the options that you have. So tell me something about medical treatment.
Sir, like initially start with proton pump inhibitors, and
Okay.
we can go for blood thinners, sir.
You mean you stop the blood thinner. You don't give blood thinners, right?
I'm sorry. Yes, sir.
Now stop the blood thinners if the patient is on it. Agreed. Give proton pump inhibitors. Okay. What are the other things that you give attention to? Mind you, you haven't got a diagnosis yet, but I'm looking at all the tools that you have, all the medical tools that you have.
Somatostatin.
Biopsy on endoscopy.
Somatostatin, very right. Okay, and its analogs, octreotide, reduces portal pressure. Agreed. Very good.
Prokinetics also, sir, we might.
Prokinetics don't have a role. No.
Propranolol
No, no,
can be
one by one. Go on. Ines, tell me. You're there. Tell me. You have anything
Yes.
else?
No, sir, like somatostatins,
You mentioned it. Okay.
yes, sir. And
Vinod, you have anything else to add?
Terlipressin.
Yeah, that's the same as octreotide or somatostatin. I agree. All right. One of the first requirements is if there's a coagulopathy, you have to correct it. So you look at platelets, FFP, and antithrombolytics. You know, aminocaproic acid. What is the other one called?
tranexamic acid.
Tranexamic acid. I was hesitant to use a trade name for it. That's right, tranexamic acid. We mentioned PPIs. We mentioned antibiotics. Why would we ask for antibiotics? Vinod gave the answer right up at the beginning of the discussion. Anybody? Nikita? He gave the answer actually. Aspiration is very high in these patients. Okay, so you've got to protect the lungs from there. We mentioned octreotide. And the one thing that you did not mention again in portal hypertension is non-selective beta blocker, like propranolol. If you have selective ones, it doesn't work. Sorry?
During the active bleeding, we give the beta blocker, sir, or it is as a control management?
Are we talking about active bleeding here? I'm looking at GI bleed in general.
Okay, sir.
So you're all thinking about a person in shock, right? I'm shocked. I've already said you resuscitate and do all this. But I also mentioned clearly all the tools that you have under your belt to be used appropriately at the appropriate time. Certainly, if you don't give these things, apart from none of this will be given orally if the patient has active upper GI bleed, right? So whatever can be given IV, you would give it. You would give platelets, FFP, you can give tranexamic acid, you can give PPI, antibiotics, octreotide, but not non-selective beta blocker. You can actually use it IV also. Okay. There is a thing called nadolol or labetalol, which can be used in IV, but it's not that important because we have much stronger interventions available today than IV beta blockers. Okay. But these are the things that you have. I won't go into the details about the dosage and where and when you use it, but all of you must look it up. What is the dosage? Classic question. Is 40 mg BD better than 40 mg OD of a PPI, of a pantoprazole, for example? Any takers?
Sir, infusion is more effective, is what they say, right?
I gave you a choice, 40 mg OD, 40 mg BD. Which is better?
BD.
Okay, RCTs have been done and there is no evidence that BD is better.
No, sir.
But infusion
Usually
is
they
better.
act
I
for
agree with
24
you.
hours.
Yeah.
Mm.
Infusion is better, but as I said, it is better very marginally because it doesn't have an effect on the mortality. But the reason I'm even raising this issue is that whenever you use some medicine or something or some operation, your mind must be thinking, am I doing it? Is there any evidence for my using this thing? Okay, and there is information available and I think you should look it up. All right, we have endoscopic options and I've made it easy for you. The options are different for variceal and for non-variceal bleed. All right, so Ines, tell me what are the options we have for a variceal bleed?
So, through endoscopy, sir,
We are talking only about endoscopy, Ines. Yeah.
Sir, we can do thermal coagulation or sclerotherapy.
Thermal coagulation
no,
for a variceal bleed?
No, sir, sclerotherapy and band ligation, sir.
Band ligation.
Yes,
are there any types of sclerotherapies that you are aware of?
Sir, we use that.
Go on. Is there any difference between the way you give a sclerotherapy to an esophageal varix versus a gastric varix, gastric fundal varix?
So I'm not aware of
Nikita?
that, sir. Like,
Nikita?
No, sir. No,
Not
sir.
aware.
No, not
All
that
right.
clear idea.
What's happening here? What are we doing here? This is a classic endoscopic picture of a sclerotherapy. Okay? That's a the white thing is a sclerotherapy needle, and they're giving a sclerosant there. So what do you use? What agent do you use? The next question. You guys aware of it? Anybody read about it? Vinod?
Sir, sodium
Tetradecyl.
Correct. STD, agreed. Go on, Nitya. You have to add. Can you add to it?
Polidocanol.
Okay, that's correct.
OK 42, sir.
I don't know what it is, but it might be there. I can't say. Do you know? So what is this OK something? I have not heard of it. Okay, go on. Next one.
I also have not heard.
Not heard of it. Yeah. Okay. You see, you can use, these are the common ones: ethanolamine oleate, sodium tetradecyl sulfate, and cyanoacrylate glue. Okay. The difference is that for fundal varices, the first two, sodium tetradecyl, STD, and ethanolamine, don't work well. So you have to use a cyanoacrylate glue for fundal varices. Okay, there are some technical issues. I won't go into it. You have to use a bigger needle, and you should make sure that it doesn't come in contact with any water within the needle, because it becomes like cement and the needle has to be thrown away. So there's a mixture that has to be done, and it has to happen in the submucosal plane. So where do you give the injection is the next question. You have varices, you're looking at it. Where do you give the injection? Has anybody read up about it? Because you guys don't do endoscopy. Sorry?
Submucosal.
Submucosal where? The varices are submucosal, right? But in relation to the varix, where do you give the injection? Okay, both intravaricial and perivaricial, that is into the varix and around the varix, can be given. What is the problem with an intravaricial bleed, injection rather? The injection site itself may bleed like mad. Okay, there are methods in which you can control that. You can put pressure and weight, even if that happens. But again, I won't go into the details, but it is important when you become an endoscopist, you need to be aware of all this. Okay, and what do you think are the complications? Sanya, you want to take a guess? You're putting an irritant, these are irritants which actually cause blood to clot in the submucous plane. So think of all the possible problems.
Embolism.
Embolism is very rare, yeah.
anaphylaxis.
Very rare. Almost ulceration. Okay, you give it submucosally. If it's very superficial, it can cause ulcers, and the ulcers can bleed much more than sometimes what the varix would have done. So that's one problem. Yes. Anything else? If you give it too deep?
Perforations.
Perforation is very unlikely. That kind of full thickness necrosis, you don't give so much of a sclerosant, but the inflammation can spread outside the esophagus. The patient can get mediastinitis, and stricture is a late complication, not a fresh complication. You give a lot of these things and it keeps on fibrosing, and you may end up with a stricture at some stage. But the success rate of endoscopic sclerotherapy is 80 to 90%. As I mentioned earlier, all of them have a higher rebleed rate, anywhere between 15 and 40%, 15 to 40%. That's something you have to understand. Now, what have we done here? Samir, you want to have a go? This is again a variceal bleed, esophageal variceal bleed. There is something bluish there, seen through the endoscope. What is it that's done? Banding, yeah, esophageal banding. These are usually done for higher grade varices. The lower grade, first and second degrees, again, you have to look up the books for the grading of varices. Okay, it's for the higher grades, you do banding, considered better than, these are all evidence-based, considered better than sclerotherapy. Repeated 1 to 4 weeks. My standard is about 3 weeks. Okay, I usually ask them to come back in 3 weeks unless they have a rebleed earlier than 3 weeks. Shown to be superior to sclerotherapy. And to answer the question, how long do you do it? How often we answered? 1 to 4 weeks, maybe 3 weeks on an average. How long will you do it? Until complete obliteration. You get down to grade 1 or just a hint of a varix and not otherwise. Minimum, usually they need 3 to 4 sessions. Sometimes they need even more. Okay, so that is how you do for endoscopic varicose bleed. Sophie, your comments, please.
Yeah, I think it's nicely covered, and I perfectly agree. Only thing is the technique is different. The intravaricial will cause less ulcerations and less stricture formation compared to paravaricial, because the spread is more in paravaricial. That's one thing which I wanted to make.
Correct.
Rest all points are nicely covered, and of course the protocol differs from surgeon to surgeon. How oftenly, how frequently, and all that. How much quantity you have injected and what you have done. So these all things, and I feel personally that applying band is more of a mechanical and less skilled than a sclerotherapy, because sclerotherapy needs to be learned over a period of time. If you master sclerotherapy, that has got a lot of advantage in many other therapeutic procedures, because that needs a precision. So of course this banding has made life simple, and of course there is a combination therapy which was used and is still being used in some of the varices, where you ligate them first and then you go, and if there are any residual things, either you can band them and do a sclerotherapy. These are all the things. And very initially we were using absolute alcohol, which was causing more damage. And because these chemical pharmacological agents were not available freely, so we were using absolute alcohol. Though it was very effective, but the complication rates were very high, like stricture and ulcer formation.
Gurushanthappa, sir? Yeah.
Yes, sir. Nicely covered. Only one point in the variceal they have to know. Not more than 6 bands at a single time. At a single time, and from below upwards. That maybe sometimes it will
That's
be
an
asked
important
for
point,
the
right? It must be most, you
Yes.
you start with the most distal part and then work your way proximally. That's right, very important. So if it's a non-variceal bleed, okay, what are your options? Nitya, you want to have a go?
Endoscopic
Yeah, we're
clipping
not talking about endoscopic, okay, clips, right?
and we can even do argon plasma coagulation.
Yes. Yeah.
And we can there are some hemostatic powders and
Very good. I think I practically said everything. You of course have a low voltage monopolar coagulation. You got endoscopic forceps which you can use. You use over the scope hemoclips. People, I have never done it. If you have an operating endoscope, you can do suturing. As you said, non-contact. It should say, I'm sorry about the spello. It's a powder spray, not power spray. And APC. Where do you use APC versus say a clip? Okay, clips are used when you have a good spurt or a big arterial bleed. Argon plasma coagulation is more effective in general oozes. Okay, if you have an erosion, for example, which is constantly oozing, it works much better. But if you have a regular vessel, sometimes we talk about the stigmata of rebleed. One of the stigmata is a visible vessel. When you have something like that, I think hemoclips work much better. Okay, and these are actually the AGA guidelines, fairly recent ones. I've included tips.
Sir,
Go on. Yeah.
sir, we did not mention about the balloon insertion, sir. Would it come under endoscopic or?
I see there are so many armamentaria that are available today. The last time I used a balloon for esophageal varices was 25 years ago. Okay, because the problem with the balloon is too many. Can you think of the problems that one may get with a balloon?
necrosis, pressure necrosis, if
Yeah,
not deflated.
correct.
It itself can cause further enhancement of bleed, sir, because of
Doesn't cause
pressure.
enhancement, but it gets displaced. It's very difficult to fix it in place. I've actually used a helmet, a helmet that motorcycle riders wear, two-wheeler riders wear, to fix it, and then we put a balloon and stuck the stem of the tube onto the grill work on the helmet, to hold it in place. It's very difficult to hold it in place. And as Nitya quite rightly said, unless you deflate it, it doesn't, from time to time, it can cause further problems. And aspiration is a very big problem. So instead of the Sengstaken tube, which does not have another port for aspiration, there is a modification. I forget the name of that tube, where there is another hole proximal to the balloon where you can actually aspirate. Otherwise, aspiration is very, very high. And that's why I didn't mention the Sengstaken tube at all. And have you ever seen it used in the last, in the last 2-3 years you have been around?
No,
I
So
doubt
we
it.
didn't.
sir, but
Yeah,
like
because
if we are unable to find any bleeder, even though so there is no role for the balloon, sir.
no,
Like,
because you have interventional radiology available, you have surgery available. So I would think that rather than have a blind big balloon blocking the whole of the the lower third of the esophagus and the stomach, I think it's much better to do something much more refined. Your comments, Dr. Sopimat?
Yeah, I agree. Only now the present role is that because 80-90% of them can, if they come in the night in the emergency, most of them can be controlled with the pharmacotherapy, but only if the night facilities are not available for therapy and the bleed continues, that may be the only indication now for using. That is Sengstaken Blackmore, where there is another port modification of that Sengstaken tube, where esophageal secretion can be aspirated. It's a complex. One should be very well trained, not only in placing, but retaining that pull, the gentle pull on the fundus.
Yeah.
In fact, we were using the pulleys to
Right.
maintain a constant pressure, because the moment the patient moves a little bit, that pressure will go up, because many
Correct.
times we fix it to the nose, other things, that won't be effective. So we were using pulley with little weight, 0.5 kg, something like that, so that the constant pressure is there even if the patient moves. That kind of thing we are doing. Now, of course, most of them go to medical gastroenterology. That's what I say, that we should restart treating all these patients. That's my feeling.
And as an extension of what Dr. Sopimat said, if you want to buy time in transferring the patient, suppose you have no endoscopic facilities in the periphery and you want to send the patient away somewhere, maybe you should use a Sengstaken tube. But the problem there is that these cases are rare. People who have the expertise to use it are not available in these peripheral places, and they can actually do more harm than good by using it. And so I would still maintain that while you should know about the existence of such a tube, I would submit that it is of historical importance. Guru Shantappa, sir?
Yes, sir. Yeah, that is true, sir. But in some examinations, YOC, this Sengstaken tube will be kept. So
Okay.
it is better you know the little bit of anatomy and how exactly what is the volume which is put in the gastric balloon, esophageal balloon problems.
Sir,
Better
can you
theoretically.
can you
Sometimes
tell
it
them
will help.
can you tell them the answers that one expects, sir, when they pick up a Sengstaken tube?
First thing they should mention is it is not being used nowadays.
Right.
Like a historical what you mentioned.
Yeah.
Second, if they know what is the importance of those two areas, that is the gastric balloon and the esophageal balloon.
Yeah.
And like both of you mentioned, during the transit to the definitive treatment and the complications. Yeah, that's all, sir.
Yeah. Okay.
Yes.
So, as I said, when you do not know the exact source of bleed in portal hypertension, remember that in portal hypertension, I'm not talking about non-PHT bleed. Then you have an option of TIPS. TIPS is generally available in all major cities. There is a 90% success rate, but please note mortality is very high, 30%. And there is a high incidence of hepatic encephalopathy also. And TIPS is not such a great tool because of this, which are the contraindications. It's a long list, as you can see. The patient is in heart failure, pulmonary hypertension, sepsis, unrelieved biliary obstruction, any heart disease, for example, portal vein thrombosis. The portal vein itself is thrombosed. TIPS is not going to help you at all. If they have a tumor in the liver, coagulopathy, encephalopathy. It makes encephalopathy worse. If the patient already has encephalopathy to start with, he won't survive. Okay. And of course, if you have obstruction of the hepatic vein, which is a very rare occurrence, then there is a problem. So not only is the availability a little difficult for TIPS, The contraindications are also many. And so as a practical tool, it's unlikely to help you very much. And that's where surgery comes in, but we'll discuss it as we go along. Okay, transcatheter embolization is also possible. I'm getting a little behind time, so I'm going to rush it through and not spend too much time on asking you questions. Transcatheter embolization is an option, and but it has very limited role in an unstable patient. If somebody is in shock and you're unable to catch up with the bleeding that goes on, don't try catheter embolization. It doesn't work. Okay, and it has a higher rebleeding rate compared to surgery, just like in endoscopic interventions, similar mortality. And please note, while the general complications like wound infection, post-op sepsis, and things like that are less, there is a distinct possibility of bowel ischemia, pseudoaneurysm, which can burst and give intraperitoneal bleed at that time, in that admission or a little later. You can have stenosis because of ischemia. That's a late phenomenon. Few weeks or months after your intervention, it can give rise to stenosis. And you can have minor complications like access site hematomas and dissection. Your catheter can dissect, and then that can cause distal ischemia. So if you're approaching it through the femoral artery, then you can end up having some showers of emboli going distally and causing ischemia of the feet or whatever distally. So there are problems. And so while interventional radiology is mentioned as a tool, both TIPS and transcatheter embolizations are not great. And Dr. Sopimat already mentioned this. So the need for surgery, as I told you, you must, in our goals or in our in the analysis of the things that we mentioned, apart from the diagnosis and the tools, using the tools that you have, you must know who are the people who must go for surgery. Okay, age over 60, shock at presentation, low hemoglobin as and when they present, if they come with a hemoglobin of 5 or 6, transient improvement with your resuscitation, and the endoscopic stigmata. Okay, so can somebody mention, this is not a very strong indication for surgery, because even with the endoscopic stigmata, endoscopic treatment can be tried and is being tried. Excuse me, can somebody mention the endoscopic stigmata of rebleed? Sanya, you want to have a go? Give me 2 or 3 simple ones. Yeah. When you put an endoscope, which of the lesions do you think are likely to rebleed even after your intervention, endoscopic intervention?
So, AV malformations, if they're there?
No, you're just looking at the lesion on the endoscope,
Visible vessel, black
Visible
dot,
vessel, correct?
adherent clot.
And a clot, and a fresh clot at that, you're right. Active bleeding,
Active bleeding.
and a cherry red spot.
Uh-huh.
Okay, these are the 4 common endoscopic stigmata of rebleed. Okay, and it's not that you should not use endoscopic intervention and go straight for surgery. You can use it, but have a very low threshold for surgery in these patients. Okay, I've just mentioned the whole lot. Okay, that is the stigmata of rebleed. Okay, so when do you really decide as a surgeon? This is where I have, an axe to grind with my physician friends. They send patients to you very late, and of course your mortality will be high, and then they go on saying that the mortality of surgery is high and so we shouldn't do it. Now, if you want a reasonable mortality, and I told you, if you do a good surgery, rebleed rate is very low anyway, then there is a good case for surgery. And so as a surgeon, you must know when is the best time to intervene. And there are criteria, evidence-based criteria. Actually, Dr. Sopimat mentioned it in the beginning itself, but I want you guys to know and I would like to know if you're listening to him carefully. What are those criteria? Anybody? Sanya, have a go ahead. She's a registrar, sir. Sanya and Nitya are our registrars. Yeah. Quickly, no time. Okay.
Early presentation.
Okay, I can't, because they're already on 950 or something like that. Okay. Continuing instability after 150 to 200 ml of fluids. You're giving a fluid bolus. It's not a very strict figure of 150. It could be even 500 ml, but the patient doesn't get better. Tachycardia doesn't come down. Pressure doesn't come up. It's still the systolic pressure in the boots. And as Sopimat said, MAP is low. Then you must have your antenna up for surgery. Transfusion of more than 5 units of blood. And the first rebleed and the second rebleed, these are in people over 60. And the second rebleed in people less than 60. Okay. So in the same admission, you have stopped the bleeding. 1 or 2 days later, he starts bleeding again. If it's more than 60, consider surgery. If it's less than 60, try endoscopic method or whatever else that you have tried before. And if it rebleeds again, consider surgery. These are the kind of, they've done this through, very careful study. And this is the kind of guidelines that the surgeons have come out with. And there are special considerations in India. To understand, you may talk about compliance, drug treatment. They may not be able to afford even simple medication. Even if they can afford it, they don't take it. That's why the cost of long-term medication comes in. And availability and safety of blood transfusion. They may rebleed anytime. Okay. And so if you do not have good blood banking facility and you can't get blood, that may become a fatal bleeding episode for them. And they live in remote areas. Okay, in the village where it takes a day for them to reach a center or half a day. And these are the things that you have to individualize and factor in before you recommend surgery. Okay. And surgical options, again, are different for variceal and non-variceal bleeds. I'll have to run through this because, what's the time now? Yeah, it's nearly 10 o'clock. The next 10 minutes, I will run through this and, our discussion can be a little bit of a problem here then. But the important thing about variceal, I'm talking only about variceal surgery, okay, not non-variceal. Dean Warren is a man who's known for his distal splenorenal shunt, the Warren shunt. Okay, he clearly says that you do not have a one-size-fits-all for variceal treatment, surgical treatment. So you have to understand, take into several factors into consideration before you choose the surgery for your varices. And these are the cause for the portal hypertension. Is it hepatic or extrahepatic? The portal anatomy, is the portal vein patent, or is there a cavernomatous transformation? What is the state of the liver function? Child's classification, you must understand that. What about the possibility of future transplantation? This is an extremely important factor nowadays, very important. So you cannot do something which makes a future transplant difficult, and many shunts can cause difficulty in doing a transplant. That's why practically all shunts have gone out of the window. We hardly ever do shunts now. And the expertise available. Many people may not be able to manage doing, complicated shunts. And so expertise available. All these things have to be borne in mind before you consider what you want to do. And when you are measuring the outcome of your surgery, as I mentioned earlier, you must understand the initial control of bleeding, rate of rebleed, the mortality of your procedure, incidence of encephalopathy, and other complications, which include things like SSI, surgical site infection, lung complication, DVT, and the like, general complications. So all these have to be measured and factored in before you choose your surgery. Okay. For portal hypertension, shunt surgery is very well known. Okay. And all surgeons can be classified basically as shunters and non-shunters. I'm a non-shunter. I have done shunts before, but that was when, just the first few years after my training. And after that, I gave it up because I was very happy with our outcomes with a non-shunt operation, which you guys didn't recognize in the beginning. I'll tell you about it. Okay. So I'll run through the shunts They can be selective or non-selective. A distal splenorenal shunt or Warren shunt. Inokuchi is another kind of a distal selective shunt. The non-selective ones are porta cables, splenorenal, and mesocable. There are many shunt operations described, but these are the things that you should know about. Okay, and these are the selective shunts, as you can see. Yes, splenocaval shunt from the splenic vein onto the cava. If you cannot reach there, they'll put a graft there. This is the classic Warren shunt. You disconnect the stomach from the spleen and the whole of the greater curvature and put the spleen into the renal vein, and a coronary cable shunt. Again, the coronary vein, instead of the splenic vein, they use the coronary vein, which is the left gastric vein, and stick it to the vena cava. These are the, I want you to just know that these things exist. I don't think you'll be quizzed about this in the exam. Guru Shantapa sir, are they still asking about shunts nowadays?
No, sir, not much.
No, yeah,
not much.
because it's really gone out of the window. And this is another selective shunt called the Inokuchi shunt. So what they do is clip the splenic vein there and put that back into the renal vein here. Okay, and they can use even a graft for that, a Dacron graft to put it up there, so that all the blood, it basically disconnected from the portal system. So portal hypertension persists, but it is not transmitted to the gastric vein, gastric vessels and the esophageal vessels. And I'll have to ask you this because I don't want to give you the answer. These are the total shunts, which are, as you can see, there are so many of them. Porta cable shunt and the H shunt or the mesocaval shunt are the common ones. I will share this PPT with you guys so you can know more about it. Just to know, it is of historical importance. Okay, and I've got another picture of a nice splenorenal shunt. See that the whole of the stomach is disconnected and the splenic vein is put into the renal vein. So what are the advantages and disadvantages of selective shunts? You want to have a go at it, Nikita?
No, sir, not much into
No,
the show.
Sanya, you want to go? You didn't read anything about it? You should have read, yeah, before coming to the discussion. Yeah. Sanya, you want to have a go?
So not very sure, sir.
Not sure. Okay. The advantages are reduced encephalopathy. Biggest problem in tips and shunts are increased encephalopathy. All right. So when you have selective shunts, you do not have that much of encephalopathy. Not that it's not there, but the problem is not very bad. Acceptable control of bleeding. As I told you, initial bleeding has to be controlled. Rebleeding has to be less. Mortality has to be less. That is true for this. Disadvantages, it's complex, takes time to do. I've done a few of these, not tried in an emergency. It's not that easy. Steep learning curve, and this is the biggest problem. As time goes, it doesn't remain selective anymore. There are new channels that are formed, which makes it non-selective and can later on increase the incidence of encephalopathy. For non-selective shunts, acceptable control of bleeding, acceptable rebleed rates, relatively less complex. So it can be, a porta cable shunt can be done much easier than a distal splenorenal shunt, for example. But encephalopathy is high. And in the interposition graft, not in the porta cable, but the H graft, that is the mesocaval shunt, incidence of blockage is high. And if you have a portal vein thrombosis, then you cannot do a porta cable, but you can still do a mesenterico-caval H graft. That can happen. So every one of them has its advantages and disadvantages. I'm a non-shunter, and the picture you see in the background of the whole presentation, all right, is a Sigura. Any of you have heard of it or not heard of it?
Heard, sir.
What's the name,
Vinod.
sir?
Okay, so Vinod, tell me,
Yes,
what does it denote? Just the main steps.
Yes, sir. We'll divide the esophagus and re-anastomosis.
That is last step. What are the things that are involved here? Stepwise.
Stepwise, I don't know. Sorry.
Okay, it has a gastric component and an esophageal component. It has an extra gastric component and an intragastric component because you have to completely devascularize the stomach. Okay. And splenectomy is a part of the procedure because most of these people will have an enlarged spleen and a degree of hypersplenism. Technically, also, it's easy to knock off the spleen, and it's good to take off the spleen because it can otherwise give you hypersplenism. So what you do is disconnect on the lesser curve in the gastric component, on the lesser curve, right from the antrum up to the OG junction, the whole of the stomach, including the coronary vein, and many times you take the left gastric artery also at that point, which means that the whole of the stomach is supplied only by the right gastric artery and the right gastroepiploic artery. And you disconnect the greater curvature of the stomach all the way from the pylorus up to the OG junction outside the gastroepiploic arcade. You have to remain outside because the artery has to continue to supply the blood to the stomach. Okay. And the esophageal component is devascularization, taking all the variceal connections all around the esophagus for the lower 1/3, which is about 10 centimeters of the esophagus, right up to the pulmonary ligament. And the access to it is either a double incision, upper midline and left thoracotomy, or you do a thoracoabdominal. I always prefer a thoracoabdominal. Do a splenectomy, and for the intragastric or intramural varices, okay, Segura himself would divide the OG junction, use an EEA stapler like thing, and then either stitch it by hand or use a stapler and put it together so that it would block off all the intramural varices. But we had a modification where we would do an anterior gastrotomy just distal to the OG junction, underrun all the veins in the posterior wall, and stitch up the gastrostomy. In the process of stitching up a full thickness suture of the anterior gastrotomy, we would achieve the blockage of all the intramural varices. This is a Segura procedure. People in the West were extremely scared. When I was training, we knew about this, but they were extremely scared about the high mortality that they had. But when I came back here, when I found that, people from the villages, or when there was a failure of endoscopic therapy, we did a few, and it became actually a very successful kind of procedure. I came back in 86, between 86 and 2000, we had done 24 cases. I actually presented this series in one of the conferences. We had a 16% mortality, almost all of them with aspiration and pneumonia. None of them with a rebleed. Okay. Even this rebleed that occurred, we could control with endoscopic means. It was very easy. But what had happened was that when the patient came with this huge hematemesis, they had already aspirated. And we went in and operated on them, and post-op, day 1, day 2, day 3, perhaps, they had bilateral white lungs. And we could hardly, even they put them on a ventilator and all that, we couldn't salvage all of them. And so you had a 16%, 4 deaths in our 24 cases. Encephalopathy did occur, but it again was transient and they did well. So in those days before year 2000, we did quite a few of these cases. But since then, our endoscopic methods and basically endoscopic methods have become so good that we have not had to do any of these operations. Non-variceal bleed, you have classically duodenal ulcer, gastric ulcer, maybe Mallory Weiss tear. I've never operated on one of these because they all settle down by themselves. Gastric erosions and some miscellaneous lesions that you may have. I'll show you one of the pictures that, I've done a few of those, but I'll show you one of them. And the approach is completely different. Now, we are now changed gaze. Remember, we are not in variceal bleed anymore. The non-variceal bleed. For a DU bleed, okay, what is the important thing in a DU bleed? You want to have a go at it, Nikita? I'll make it even simpler for you. What's the important difference between an operation for a perforation and a DU bleed?
Sir, most of the times DU bleed will be posterior aspect.
Okay.
So we can't actually rent closure can't be done, sir.
Why not? Why not? Every rent can be closed by a surgeon. You can do it, of course. You can create a rent and then close it also. That's what we do all the time. Sanya, you want to have a go? Okay, no time. You have to underrun the vessel. If it's posterior also, you do an anterior rent. In other words, a duodenectomy, underrun the vessel. But a definitive procedure is a must. That is the important difference, okay? Otherwise, the rebleed rates are very high. Remember, you can't depend on PPI for this. So you must do a truncal vagotomy and drainage in addition to your underrunning the vessel, or you can do variations of a posterior truncal vagotomy and an anterior seromyotomy if you're worried about the problems of GJ. And of course, HSV is out of the window. I put it there for the sake of completion. Highly selective vagotomy is not done nowadays. We used to do a lot of these, 20 years ago, 25 years ago, but it's not being done now. Okay. And in a gastric ulcer, what would you do? What operation would you do? Sanya. Okay, Vinod, go.
For type 1, we'll do distal gastrectomy, sir.
Okay.
And for type 3 and type 2, we can do PPI is enough.
PPI is enough. I'm talking about a situation where it needs surgery. Yeah? I'm not talking about
distal
PPI is enough.
and Sendis pouchets.
Sorry?
Sendis and pouchets, sir.
Oh, you have to educate me about these names. I don't remember names at all. Yeah, what is this Sendis and pouches? Tell me, please.
Sir, for type 4 lesions, they will do almost 75% of the stomach is given out.
Please understand, when you have an ulcer that's bleeding, you can excise the ulcer.
Yes, sir.
Okay, just excise the ulcer, and it doesn't need a definitive operation as a compulsory method as in DU. Okay, because many of these gastric ulcers are anhydric; they are not hyper secretors. Okay, and of course, if you're worried about, you can do an excise. You can excise the ulcer and do a TV and drainage, and as a distal gastrectomy or partial gastrectomy can be done also. And if you have a diffuse, tremendously severe gastritic bleed, you will have to consider a total gastrectomy. Okay, these are your options. And miscellaneous conditions. What is this condition? It's a classic condition that I did a few years ago.
Dulophoid.
Dulophoid doesn't give you a lump like that. There is an umbilication in a lump on the posterior wall of the stomach. I've done an anterior gastrotomy, and you have, this is the visible vessel for you. You can see all the cherry red spots, 3 or 4 of them. It's a visible vessel, and it's on an ulcer on a lump.
Gist, sir?
This is a classical gist. You cannot miss it. Okay, this is a classical gist. So we just excised the whole lump there and then stitched up the posterior wall and then the anterior wall, and that is all there is to it. Okay. I'm sorry, I rushed through the surgical aspects a little bit of an irony because we are surgeons and this is what we should have spent time on. But the subject is such that it is mostly non-surgical at the moment. Guru Shantappa sir, your comments, sir, before we close.
Sir had left a message.
Message is left. Okay. Supimat sir.
No, nothing much to contribute. I just enjoyed. I think if they can understand the basics of this and principles behind investigation treatment, I think that should be enough at this stage. Yeah. And you're nicely covered. I think I must compliment you and your team members for the enthusiasm that is shown to share the knowledge. And they are very proactive guys. And that makes me happy. That makes me happy.
Thank you. We will. Please do join us. We will really appreciate and enjoy your inputs. I think they're very, very valuable to the students.
Thank you so
much. Thank you for joining, Sopima. Okay, Sanya, any questions from the students, please, before we close? Sorry?
Sir, what I read is during the emergencies, no need to do within 12 hours, advice to do endoscopy after 24 hours, something I read, sir.
Okay, there's a big debate. I know what you're trying to get at, but I'll tell you the final verdict there. There is a big debate as to whether an emergency endoscopy is going to make a difference to the mortality. There are some people who say that it does improve the mortality if you do an immediate endoscopy. That means patient comes and within a few hours, you do an upper GI and you find the cause and you treat it. There are others who have shown with solid data that it doesn't make a difference. So basically, it boils down to whether you can have an experienced endoscopist on call round the clock. And most senior surgeons or endoscopists who can do things with their endoscope don't want to get up in the middle of the night. So you have data, they have produced data which says it doesn't make a difference. And that debate is going to continue. All right. But by and large, in the middle of the night, I think it is much better that you resuscitate the patient and make sure that you have all the other things like coagulation parameters and other things controlled. And I do not think it makes a big difference if you endoscope them. But if you cannot maintain it, my practice has been I go in the middle of the night. Anytime if my resident tells me that the patient cannot be stabilized with the IV fluids and the works and then 1 or 2 units of blood. Mind you, my threshold for intervention is 5 units. So well before that, I go in, I endoscope them. If I can manage it endoscopically, I do that. Otherwise, if they're still unstable, I'll take them off for surgery. You got what I said?
Yes, sir.
Yeah.
Thank you.
Okay. Anything else? Final comments?
Sir,
Yeah, go
role
on.
of angiographic embolization, sir.
I mentioned it, no? Yeah, when the patient is unstable, don't try angiographic embolization. I've mentioned it, it has limited role because its complications are not few, very few. And effectivity is good, but it's not an option in hemodynamically unstable patients.
Okay, sir.
Yeah. I think we should have, Dr. Sopimat made this point, we should have a low threshold for surgery if you want to save the patient. If the patient comes on the operating table after failed angiography, failed endoscopy and all that, you're dealing with an extremely brittle and vulnerable patient and your mortality is going to be very high. So you should have a surgical intervention. As I keep repeating myself, it has the best results as far as rebleed rates are concerned. Control of bleeding and rebleed are the minimum with surgical methods. And so we should be game for that. We should be ready to do that. Okay. All right. Thank you. Thank you very much. I'll close the meeting. Sorry, Sanya and who else? Nikita and whoever else, please, Nitya, your comments before I close.
Sir, very enjoyable class, sir.
Okay.
We are enjoyed the class, sir.
Thank you. Sanya.
Yes, a very nice class in
Yeah.
detail and in stepwise.
As I keep telling you, I need a critique. So what does critique contain? Good points and not so good points, like we do in journal clubs. Okay.
Yes, sir.
So
But
is there anything else that you would have liked me to cover?
no, sir, I think
No.
most of it, like almost everything is covered.
All right. Okay. All right. Good night. Good night.
Good night.
Bye-bye.
Sir, hello.
Yeah, go on.
Sir, you said we have given a high selective vagotomy, sir.
Yeah.
Why is it?
It is a very high recurrence rate. I was one of the biggest proponents of HSV when I came back to this country. I had learned it from the guy who actually designed it, okay? And I was a great follower of HSV. And what happened was that I think it wasn't done very well elsewhere in the world. And it may sound like a bit, bragging, but I'm not bragging, honestly. The guy who designed it kept on saying that people don't do it properly. And so if you look at the world literature, the recurrence rate of ulcers for HSV was very, very high. So the world gave it up. And all these guys who were proponents of HSVs were, reduced to a very small minority. And I was one of them. And of course, HSV is something that is not an operation in an emergency. We have completely, HSV is not recommended for a GI bleed, a big bleed at least. Okay, a small ooze, you might get away with it, but not a big bleed. And by and large, the world has given up HSV because of the high recurrence rate. That is the answer.
Sir, in truncal vagotomy, you will include gallbladder also, sir, as a surgery, part of surgery?
No, it's not recommended. The gallstone incidence is high after a truncal vagotomy, but because of that, cholecystectomy is not recommended. Because the incidence of that higher gallstones is very, very minimal. It doesn't make big difference clinically.
Okay, sir. Thank you, sir.
Okay, thank you and good night, everybody.